our Playground Founders series. This one is entitled Back to the Workplace in the Era of COVID. I'm Phyllis Whiteley. I'm a venture partner here at Playground Global. We actually have an exciting event planned for you today, but before we get started, let me just start with some housekeeping information. I know we're all pros at Zoom, but at this point, let me just cover a few things with you. The fireside chat is being recorded and will be shared with all of you following the event. Your audio and video are muted. There will be a live Q&A session at the end of the fireside chat. You have the opportunity to ask Mara questions using the Zoom Q&A feature. If you have any questions or Zoom issues, please use the Zoom chat feature. Without further ado, let me introduce Mara. You know, Mara Aspinall and I go way back. I think it was in 2005 when we first met on the board of the Personalized Medicine Coalition. And our goal there was to convince people to write legislation, convince patients, doctors that personalized medicine was the future. It seemed like a daunting task. I think now in retrospect, Mara and I would both agree for all the stress and concern and hard work we put into the Personalized Medicine Coalition, a group in Washington, D.C., we have much harder things ahead of us. And so Mara is going to talk about that. Before she gets started, let me just tell you, she's the managing director of BlueStone Venture Partners. She also heads the Health Catalysts Group, publishing the popular Health Catalysts Diagnostics Year in Review, and something everybody should read, the COVID Weekly Testing Newsletter or Aspinall Testing Newsletter. She's an advisor to the Rockefeller Foundation on COVID diagnostics, so she's been intimately involved in this since nearly the beginning of our whole crisis. She's a co-author on the Rockefeller Foundation's national reports on COVID and heads the implementation of the National Testing Action Program for school testing. Mara has been passionate about diagnostics for much of her career, and she co-founded the School of Biomedical Diagnostics at Arizona State University. That is the first school dedicated to diagnostics as an independent discipline. Previously, she has served as president and CEO of Ventana Medical Systems, which is now Roche Tissue Diagnostics. Before that, she was the president of Genzyme Genetics and Genzyme Pharmaceuticals. She's also been very involved with the government. Aspinall has sat on the U.S. Health and Human Services Secretary's Advisory Council on Genetics, Health and Society. She did that in both the Obama and Bush administrations. And she's also very closely involved today with the Biden administration. I think Mara is probably one of the best people here to teach us about what we should do in the workplace and to show us data on what's really happening with COVID. So without further ado, I'm going to turn this over to Mara.
Phyllis, thank you for that very generous introduction. It's been a pleasure and an honor to work with you over the years and have the chance to really make an impact in the life sciences and diagnostics industry. So hello, everybody. I'm going to go through a fair number of slides pretty quickly. It's a pretty sophisticated group. And what I'd like to do is ensure, as Phyllis said, that we have plenty of time for Q&A after the slides. So I'm going to make all of these slides available. So do what you need to do, but you don't have to take the notes because I'll make sure with Phyllis and Sylvia that you'll have all of the slides. So as you know, we're talking about getting back to work in the midst of the COVID era. I'm going to start to ground us and talk about cases of death. I think it's unfortunately clearly part of the story. As you all know, we're in the midst of the fourth surge. Is it leveling off? One could debate, but I'm going to focus on the bottom numbers here, the case fatality rate. Arguably, you know, what happened from the initial 7 to 1.8 to 1.3, we got better at treating people and diagnosing them a little bit earlier. I'm going to say virtually all of this positive, even with the surge, getting to 0.8% in terms of fatality is all about the vaccine. And for those who think, well, it's now approaching the flu rate, the flu death rate in the worst of our flu seasons about 8 years ago was 0.14%. So we are still 4 to 5 times higher than the flu. So if we take that death rate, why has it happened? At least the fourth surge, it's all about Delta. Not since the beginning of the pandemic did we have one variant, initially Wuhan, responsible for virtually all of the cases in the US. We're at 99.7% of US cases. And to give you a sense of how quickly Delta got here, Alpha, which was initially called the UK variant, took 3 months to get to a majority. Delta took 1 month to get to majority, and it has just steamrolled ever since then. It seems to be, unfortunately, a pretty fit virus. Do vaccinations work? Because we wouldn't have this many people if vaccinations were 100% effective. No, they're not. Particularly, unfortunately, the J&J virus, but any and all of the viruses do make a huge difference in terms of both disease incidence, 8-fold, hospitalization, death at 25-fold. So even with breakthrough cases, you guys probably know, because I'm going to assume you're a highly vaccinated group, but I wanted to give you the data that it does make a difference. You only have to look at the national data. I don't know, Florida is always an exception with everything. But when you look at the correlation here between death rates and vaccination rate, it is very clear. States like New England, who have a super high vaccination rate, not high enough, are lowest in the death rate, and states that have a low vaccination rate are highest in the death rate. We can debate about Florida. What is it that works in a variant? You're probably aware of this, so I'll go through it really quickly. The random mutation occurs, but it's only when more mutations occur. The WHO has called 3 different groups: variant of note, that kind of worth watching but hasn't changed anything; variant of interest, like mu and lambda are here in variant of interest, but it doesn't get to a VOC or variant of concern until we're clear it has an impact on patients. We can talk about what the next variant is likely to look at. But when you have those variants, the real question is, and Phyllis knows I ask this a lot, the so what question. Well, great. What are the questions that really make a difference? And while I'm doing this, I have the black background here because this is an electron microscope from University of Utah, from Janet Iwasa's lab, showing, obviously colored, but an actual SARS-CoV-2 cell. And clearly those green things are the spike proteins. So what are my 5 questions? One is, do tests still work, or are they less accurate? The answer is they're not less accurate, they still work. Is there an increase of cases and death? The answer is clearly yes. Is it more virulent? It's not clear, but there is clear that there's higher viral loads with Delta. Does it make treatments ineffective? It does, but a little less so now. You can't get an antibody from somebody who had Alpha and use it on somebody who has Delta. We've now had so many recovered patients on Delta that antibody treatment is coming back up. Does it reduce vaccine effectiveness? I say reduced, it's probably fair to say yes. And does it raise the hurdle for herd immunity? Absolutely. No question, you don't hear the 70% herd immunity very much anymore, because with the infectivity of Delta, average person infects 7 others. We need a much higher hurdle. So if we understand that as a baseline for all of us, I now want to go into a recent survey, and you'll see a lot of data here about workplace. I think that's the core of our discussion today. How has the workplace changed, and what is COVID's lasting effect? So my co-author and I, is Nate Wade. This is through a grant in the Rockefeller Foundation. I'll also send you the report itself. Long story about the methodology, but all of these surveys were done in the first 3 weeks in August. Lots of questions and 1,600 responses. I believe it's the largest detailed survey in the COVID era. Our overview, first of all, this is mostly US and UK. This is the 3rd of our surveys, and we decided to focus just on these 2 countries because having 4 people in Turkey and 6 people in Japan really doesn't give you a sense of it, so we're focused. Many of you are in tech and software. That is our #1 respondent, but followed closely by business services, but not all white collar. We then go quickly into manufacturing, construction, and retail. We think that this is representative. It's mostly larger companies, 78%, 250 or more. So what are our insights? I wanted to show you these. You can read them quickly, but I think it's better to show it in pictures. We were very aggressive in this report, and the US government is now using it as a model of what we call text light, picture heavy. And no value judgments there, but the reality is most of us would rather see pictures and graphs than a whole lot of text. So let's talk about the survey itself. Employers, the COVID task force is very pleased about this. 93% of employers require or strongly encourage employees to be vaccinated. What a requiring rule of that requiring is 61%. So it's not 100, but we were really pleased that only 7% of employers said they would not encourage it or actively discourage it. The actively discourage it appears to be less than 1%. And I can't give you a breakdown in terms of names or industry on that question because it was all anonymous. But what about how they want to vaccinate? I thought this would be very useful for all of you to understand. First of all, we think that the next stage of the pandemic, and we'd hope to get to it now, some large employers are doing it. 80% said people can be vaccinated on their premises like flu. 68% is actually encouraging the actual proof of vaccination. 56% require it. We found that in the tech industry, fewer people are requiring that. There's sort of typically smaller companies and they're assuming employers are going to be honest about it. What are the consequences? It's all over the map here. And as you can see from this circle, no one answer, everything from no consequences to change in a work responsibility to disciplinary action. We're seeing more and more companies, this is the screen at 30%, who have a no flexibility on vaccination, vaccinate or terminate it. But are they giving incentives? We expected this to be a little bit more. This was a multiple choice question where companies were allowed to give more than one response. So there are multiple answers. Number one was additional paid time off, closely following by number two, which was just plain cash. Average cash was about $100, but we saw some companies as high as $500 and some as low as $25. So that's the vaccination piece. I'm going to go into a little bit more depth on testing, which is my area. We found this was higher than we expected. It had been 68% and moved to 70% of companies testing all or some of their workers. The vast majority were testing for viral infection, but this also included some who were doing environmental and surveillance testing. Why did companies not test? Number one and number two, too costly and too complicated. I would say this is perception because the change in cost has been pretty dramatic, but we wanted to get what people thought of it, and it helps deal with this, particularly in cities and states that want more companies to test. What I'm concerned about is 19%, and this went down from about 25% in the last survey in the fall, but still saying they're concerned about test accuracy. So how have tests changed? A little bit of a diagram here, just to give you a sense of it. It started out, way at the beginning that the only way to be diagnosed with COVID was a bronchial lavage in an operating room. It moved to active disease diagnosis, PCR and antigens, moved to screening, and now into surveillance. Where were these done? It moved from hospitals to central lab to point of care to home tests. How invasive? Very. To what I would call today non-invasive or passive, saliva to breath tests. And then what is the cost? We're now, with President Biden's speech at about $7 a test, but I think that the number will go to below $5. And for many pooled testing in central labs, it is at less than $5 a test. How many tests are there? You'll see in the chat a link to testingcommons.com. The answer is a fair number, more than 400 from the FDA, and in Europe with the self-certification about 750. How do they align? I won't go into detail here, but the vast majority of authorizations are still in molecular tests. The antigen tests are gaining. They're never going to be nearly as many antigen as molecular, but these are the ones that are the home tests. And if anyone's interested, I have a couple to show you. Antibody tests are the tests done in blood, hence in red. These show past infections. The first two show current infections. These antibody tests have never done well in the US, doing well some places outside of the US, and the FDA has revoked approvals for 162 of them, and there are only 80 approved. So lots of quality problems with antibody tests. So, but the focus today is on antigen tests. You might have seen even in today's Wall Street Journal, we need more rapid tests. So what rapid tests are out there? Again, as a reference, this is the last approval was 3 weeks ago. But this gives you a little matrix of these are all comprehensive at-home self-tests. I emphasize comprehensive because a lot of things out there like Pixel says it's an at-home COVID test. It isn't. It's an at-home COVID collection system. So if you buy them, make sure you're not buying a collection system for which you have to send back and then wait for the results. These are comprehensive. You do it at home in the privacy of your own living room, and you get an answer in 12 to 19 minutes. This are very different, 100%. Molecular tests are typically $40 to $50 to $70 each. These antigen tests are at most $25 for two. The OTC ones, you don't need a prescription. These are still available at the top, but you need a prescription to do it, but you still do it at home. I'm going to come back to this if there's a question. What else was in the survey? Employee well-being. This hugely jumped. Employers are saying mental health is now their top priority, 3/4 of them. But interestingly, they found that employees are using their mental health resources. They saw the mental health concerns, but they also see increased engagement, increased productivity, but increased burnout. It's an odd combination of everybody working really, really hard, but scared as to when this is going to end. What about going back to work? We found that employers believed that 83% of employers believed that the majority of their employees wanted to get back to work, and only 11% had a negative return to coming back to work. So what did that translate? Why were people concerned about coming to work? Again, no overwhelming answer. Number one, 56% said it was my personal health, very closely related to safety. This was once again one of these things that you could answer multiple responses. The number 2 one, if we combine these two, is essentially the same, is childcare. But what about the future? Are we going to work any differently after COVID? And the answer, interestingly, is yes. We found 66% said that this work for home thing is going to stay for a long time, but virtually all of them said, I want employees in the workplace at least 20 hours a week. So this 100% work from home is something that very few, if any, supported. What's the challenge there? As we talked about, employees not wanting to go back to work and back to safety. So what do we believe is in the future? And, you know, as many surveys, we ask the same question multiple times to see that we get the same answer. 42% said it's going to be a combination of physical and virtual. Only 32%, very consistent with the 66%, say we're going to be all physical in the future. So what are the challenges? And I'm going to end after this so we can take questions, but this I found really, really interesting. The anti-vax people and people who are saying it's not safe, you know, you're imposing too many mandates on me, was interesting. 39% of employers stated employees had resigned due to over stringent workplace policies. But 55% said they hadn't get resignation. Sorry, the 39% was overall. But if we say, why did they resign? 42% said lack of COVID policy at all. 39% not restricted enough. 17% overly restrictive. That is a big deal. So this overly restrictive is a minority. And as I conclude here, what I wanted to say is there's a lot of press this week on more people have died from COVID-19 than the Spanish flu. And I don't know about you, but I get emotional when I look at this. I lost one family member and 4 friends to COVID. And by the way, only 2 of them were over 70. The rest were in their 50s. Excuse me, when I look at that, I never imagined we would be more than the Spanish flu. It's a smaller percent of the total people. But wouldn't we have much better healthcare now than we did literally 100 years ago? I don't know what to make of it, but I thought it was important to sort of look at the broad scope of epidemics and pandemics and where we are. There are certainly ones up here that have a much higher death rate. What's interesting is the ones with a much higher death rate, like Ebola, they kill so many people, they can't actually continue for long periods of time. But we have this perfect virus here with Delta. It kills a lot of people, but not enough from the virus's point of view, and it keeps living. There are some things that are more contagious, and my worry going forward is that Mu and other variants to top Delta have to be more contagious. And I just hope we don't have to go there, for more people to get vaccinated and for us to use testing to restrict the spread. So excuse the commentary at the end, but now I wanted to open it up, work with Phyllis to answer your questions about any of these slides or other areas. Thank you.
Well, thank you, Mara. That was really helpful. A lot of information there, and we're very pleased that we'll be able to have those reports, and so people can really dig down into them. While we're waiting for questions to come in, I have a couple that Mara, maybe you can address. And I think one of the things that I really think a lot about is self-reporting of vaccination enough. When we talk about, we have a certain number of employees who are vaccinated, or do we need to have proof of vaccination?
A great question. I think that in small companies where everybody, I believe that it's not necessary to prove the vaccination. But with larger companies, when we start talking 100 and more, where you don't know everybody by name and you don't know where they are and what they're doing, unfortunately, I think proof of vaccination is necessary. What a lot of companies have done is, I don't want to say hide behind, but said, like so many of our other policies, we need to ensure compliance and therefore give us the form to do that. So I would say people are moving more and more towards that. Unfortunately, partly because of the vaccine mandates, they don't want to lose their job. And we know that at least some people are capable of lying. So I think that if you put in a prove the vaccination card, you will now be in the majority.
Mm-hmm. Well, thank you for that. Again, I encourage people to submit your questions. Mara, one of the things that I find really confusing is the utility of the rapid test, since it seems like in many cases, and I know this from daycares or from some work environments, that you do the rapid test, but they still want a PCR test proof. So I start to wonder then, so what is the utility of the rapid test? So if you could go into a little more depth on, for a period of time, it was said there were a lot of false positives, how they've improved, but do we need a PCR test after a rapid test?
Well, it's a complicated answer, but a critical question. I think from an analytic clinical basis, treating yourself, the answer is no. I just took a rapid test last week. If it had been a yes, it is a yes. Unless you're doing your test in a hospital COVID lab, if you're doing it at home, I would absolutely trust positives from rapid tests. If you expect it to be a negative, I would do 2 tests. And I think everybody may be familiar, but if you're not, just like most diseases, but you could be negative in the morning and positive in the evening. You know, there's a day for which you don't have a cold, and then the next day you have a cold. There is a start to every disease, and the rapid tests are not as sensitive, i.e. there are some false negatives for about 14 hours that you might at the same moment get a negative antigen rapid test and a positive PCR. Hence why the FDA has called all of these serial tests, all of the over-the-counter rapid antigens serial tests. You got to do 2. And if you do 2 negatives, I am fully confident. You do 1 and you get 1 positive, I would call that a positive. Why do people say you need a PCR? 2 reasons. One is tradition. And just like Phyllis, you said about personalized medicine, people don't believe it. You get a negative HER2 test and they say, let's just try Herceptin. And, you know, we can change people's minds, one person and one clinic at a time, but we're not going to change the world. The second reason, maybe that you should get a PCR test, and I'm so sorry to have to say this, is if you get long COVID, there are some payers that are making it very difficult and saying, this wasn't brought on by COVID, we won't cover it. And the rapid test, for the most part, what do? You take a picture of it at home. You take a picture of your test strip, and you then don't have a confirmation through a healthcare system that you got a positive COVID test. And a lot of payers won't take your photo. I can show you my photo from Sunday. That would be the only reason, if you're really concerned that you have a difficult payer, I might get a second test.
That's very helpful. One of the questions that's come up from the audience is, what are your favorite at-home tests?
Well, let me say this, and I might, if people don't mind, I can show you a few. But I'll be clear, I am on the board of AuraSure, which is one of the tests called IntelliSwab. So I don't want to overly focus on that one, but this one, and this actually was my test, you could see a control, 1 line like pregnancy and not 2 lines. And by the way, I did this days ago, so it's still good. And this one is an all-in-one. But when you look at the other tests, like Quidel QuickView, it's several different pieces as I'm going through it. And the answer on this one is literally a strip. And you could see my negative test right there. I had dinner with people, so I wanted to take some tests. So they're all a little bit different. I think the best answer in a great way is that all of the tests are FDA approved or within about 1% of sensitivity and specificity. So it's all about what you can get. The cost for the Abbott test, and this is, I love showing these, this is the Abbott Binex test, which looks, and Phyllis, I'm going to stop here in a minute, but looks a little bit different. And this is a card. I'll see if I have one open, but they're all essentially the same. I won't go through any more detail. The antigen instrument tests are slightly more sensitive and slightly more accurate, but it's very hard to get those today unless you're in a nursing home.
Okay, thank you. We have some other questions here. What are the key indicators you are watching to determine whether the current surge will continue or abate? Yeah.
Well, number one, vaccination rate, but it's not going to help in the short term because it's at least a month till somebody's vaccinated. Some of the labs in the country are looking at viral load indicators. Most of them are not. I have publicly called for the fact that we should change the way we report tests and understand viral load, but I don't know that that's happening. But I'd look into the Broad and some of the key labs to see that viral load numbers going down. I think, unfortunately, there are only 2 other indicators. One is number of tests done, and 2 is positive rate. I start with number of tests, even though the world is starting with positive rate, because the positive rate is just not accurate. You get into states where virtually no testing is being done, no screening is being done. All the tests are people with symptoms, and you're going to get a 20% positive rate. And then they do in a bolus of testing, and all of a sudden says, oh, Alabama looks much better, we're only 10% positive. It's because the denominator changed. So you have to, unfortunately, the only reliable indicator today is hospitalization rate and cases.
Thank you. Here's an interesting question that I think also applies to employees, but can you talk about the effectiveness of schools' policies on quarantining children who have not been in close contact to a positive test case? And maybe, I know you have some analogies to that in the workplace.
Yeah, and you remember I said there's one slide that I'll come back to later. Thank you for setting up that question, because this is the slide. Oops. This is the slide. And in showing you this slide, I'm just going to make it full screen. Some of you may have seen the New York Times article. There's actually an AP article that just got out that I talk about this in AP, which is called Test to Stay. Now, this happened in the UK in July. They had Delta at the time. They looked at 162 high schools. They put it in a control group with 76 and an intervention group. The control group is the standard. If they get a case in a classroom, everybody goes home for 10 days of quarantine. What they then said was, no, let's see if we can do it differently. And they said, let's not send everybody home other than the obvious positive. Let's test everyone who's been exposed for 5 days, every single day with a daily antigen test. And what they found was you still had more cases. So let me just be clear. You had increased number of cases. Some people did get it. But by not sending everybody home, you had 40% fewer lost days amongst kids, 60% fewer lost days amongst staff. So my analogy for the workplace, I'll leave this out for a moment, is if you have a positive case in the workplace, but you have a workplace where you want people to be back, they want to be back, you don't want to send them back home, do daily testing. What you can't do, my recommendation, is put your head in the ground and say, sorry to be blunt, you can't just say everybody feels fine. And therefore, we're, just kind of keep coming to work. Because while your population might be youngish, healthy, and otherwise, they all see their great grandmother, on the weekend, or they see little kids. So you have to test after you have had a positive case. And I've said many times, the 3 most dangerous words in the COVID era are, I feel fine. 40% of people with COVID have zero, really zero symptoms, not a headache, not a cold, not an achiness, zero. And there are very few, if any, diseases that are like that.
Yeah, thank you for that. I think sort of related is another question from the audience. And that is, what are acceptable alternative procedures if you have a vaccine requirement, but have an employee with an exemption? So how do you know that you are asking enough of them to make the vaccinated employees who work with this person comfortable, and the company comfortable, it has reduced the risk to the employee?
Yeah. So first, let me just talk about exemptions. I can send this out as well, but the Vanderbilt website has a list of like 20 religions and how they feel about vaccination. And so for religious exemptions, I was working with a college and like 1/3 of their students said they had religious exemptions. And then religion after religion, they do not have a problem. I think Jainism, which is a very odd, small religion that doesn't like to kill even minute particles or amoebas, they have agreed to vaccination. So there are very few legitimate religious exemptions. Clearly, there's some medical ones. One is I would make sure the doctor gives it. Good example, in a hospital near here, everybody assumed they would, and at the beginning of the pandemic, beginning of vaccination, everyone assumed it was not safe for pregnant women. Not only is it safe for pregnant women, the highest load of babies in NICUs in these high areas are pregnant women who had trouble breathing, whose fetus and babies to be had a problem breathing. So I just can't emphasize that enough. That being said, for people who are not vaccinated, who can't be for whatever reason, they had Guillain-Barré last time, they need to be tested once a week at an absolute minimum. And if you're dealing with the public or a high risk situation, I would test them twice a week. With Delta, the incubation period is shorter, 2 to 4 days, as opposed to 3 to 6 days. Hence why twice a week is not a crazy, it's not overdoing it, but once a week at an absolute minimum.
So if you're working in an environment where you know everyone is vaccinated, do we still need masks?
Can I just go back to the other one for 1 second? I'll come back to masks. If you have options, and this may be a little bit of inside baseball, test your people on Tuesdays. That to me is the perfect day. If you're worried about their weekend plans, don't test them first thing Monday morning. Because if they were exposed Saturday night, they may still be way on their way to being positive, but they won't show up on any test, even PCR. So Tuesday, Wednesday to me is the sweet spot. If everyone's vaccinated, it depends on your risk profile. I think more and more companies are saying you need a benefit for being vaccinated and we want people to be back to work. So you could probably go without masks in a population that you know well and that doesn't have high risk moms, dads, grandparents, and young kids living at home. That's what I have recommended in the few places that I have been. We've gone without masks, but we confirmed that everyone's vaccinated. I think that's reasonable. If people take a 2-week vacation and they're coming back to work, you might want them to, vaccinated or not, might want them to test before they're coming back and have that person be in a mask.
Right. I think I have a question to what you just said. When you say test once per week, does that mean 2 serial negatives counting as 1 test or 1 negative test result per week?
Yeah. You guys are so smart. The reality is virtually all companies are only doing 1. If you read the letter of the IFUs, the instructions for use and the approvals, the FDA would say 2. Personally, if you have an unvaccinated, you could maybe get 1 test kit and split it up and do it every 2 or 3 days or 3 or 4 days, do it on Tuesdays and Fridays. So you're maximizing the use of it. But if you're doing it at home because you're going to a wedding, I would definitely do it twice. But the reality is most employers are only doing it once, even if the instructions say 2.
That's very helpful. So it's just been announced, and this is another question from the audience. It's just been announced that vaccinations have been approved for children 5 to 11. Do you have any insight on how the clinical trials for children under 5 are going?
Well, one caution is the advisory committee voted yes on the 5. I don't know, maybe it happened this morning. I think there's one more step before the 5 to 11 come out to everybody. But I don't have a lot of insight except what I've heard publicly. And I was a bit surprised, but Tony Fauci said it's likely to happen before the end of the year. So the trials are well underway. And since this one happened, he had originally said October and it happened in September. I'm going to guess by Thanksgiving, we'll get an indication and it'll be available before Christmas.
That's great. Do you know if it's still 1/3 the dose for the under 5?
I don't know. And it may be different by vaccine. Pfizer clearly seems to be ahead. But there's more RNA in the Moderna vaccine. So there might be different by vaccine.
Great.
It will be different, I suspect.
Great. Another question that's come from the audience is, what sort of differences would you recommend in your advice for non-employment situations like orchestras or large events?
I think there are 2 ways to go, and there are a lot of weddings and there are new apps now that guests can upload their their card onto a website. And, the honor system is important, but this takes it away from the bride and the groom since they're not asking, and that it's done through an app. I think that it has been, I think the best way to do it is negative testing, especially if you have a group like an orchestra or a large group where whatever's going to happen, you've got some anti-vaxxers, but you need the cello player because there aren't 4 of them, is to be able to aggressively test. Religious services, I did that in my temple this week. We had vaccination required and a negative test. And that what made everybody comfortable to do. But on that test, I think the ideal way to do it is to buy, for an organization to buy enough tests that either you can subsidize it or the organization to pay for it. So to make sure somebody doesn't like, oh my God, I forgot that, I have to go get a test today and the performance is in 6 hours. I feel fine and I was vaccinated. You've got to avoid that and, have strong compliance.
Right. So again, back to your question though, of the negative test, is that one
sorry.
test or 2 tests? So you're vaccinated and you're going to a big event or you're coming back from it. You're going to a wedding and you're requiring vaccination. Is it vaccination and 1 test or 2 tests?
It should be 2, but I know that people are doing 1. And they're satisfied with 1. So this is a don't let perfect be the enemy of the good. It should be 2 in high risk environments, but I would say most are not doing 2.
Okay. Another question from the audience: as we head into flu season and fall and winter, what should we be most concerned about?
There are 18 tests approved now. EUAs for flu and COVID together. I suspect that number will increase by 50% in just the next few weeks. Why do I say that? What does that mean? It means that if you go into your doctor's office with anything, you're going to get a combined test. I think they're going to be virtually no flu tests run alone unless there's a supply issue. Even though the symptoms are slightly different, they're not fundamentally different. And I am 100% sure, we'll put money on this, we will have a flu season this year as opposed to last year. So it's cautious. I don't recommend people do flu testing at the office or even talk about it, because flu 99.9% of the time has symptoms. So if you have symptoms, you don't want those people coming to the office to pick up a test or to get a test in the office. If somebody has symptoms, they don't come to work. It's probably overly cautious.
That's great. Thank you. I think one topic you and I have occasionally talked about, which I thought was really interesting, is what is the right social distance space? So we all hear 6 feet, and you go into any store and they say 6 feet. Is that really meaningful, or how do you know the right number?
It's not meaningful, and it came out before it initially came out before we had masks. If you're being super cautious, I am. If you can smell something, if you think about something on the stove and where you can smell it, that means there are particles in the air. Smell is just particles in the air. Besides the fact that if you can't smell it, you might have COVID. But this is that small. If you sneeze in a closed room, it's probably everybody in that room gets some of those particles. So the best way to do it is to have, like a playground, very high ceilings and high ventilation. People ask about HEPA filters and all of those. They help, but I think you want to be cautious. You don't want something that just blows everything around because it actually could make the situation worse. Airplanes are actually reasonably safe because they push the air from above you down and then recirculate from the ground, modern airplanes. And that's probably the best way to do it. So the answer is, if you can smell that somebody was smoking or, otherwise, then you're probably too close and you need to have more distance. But the reality is, I find it's really hard to maintain that distance and work with each other. It just, I think it's one of the least effective mitigations if you're back to work. because you don't notice it. And if you spend more than about 3 minutes with people, you end up too close to them. So I think in those situations where you're working close and you want to be really cautious, go back to masks and don't worry so much about distancing, because there is no perfect number. And I did a study, I'll be quick on this, on a bus in China where somebody in row 7 was sick. People in row 1 and row 14 got it, but some people in row 9 didn't. You know, it's not that simple to track.
Wow. Are there any more questions from the audience, or please submit them if you have some? Okay. While we're waiting for any additional questions, Mara, did you have some additional points you wanted to make? I know that I made you cut your presentation down, but I know you have a lot more to say.
Yeah. Let me share my screen. So some other interesting data from the survey, particularly for businesses to understand what % of increases of your operating costs are COVID related. And we thought this was sort of interesting. You know, there are 2 ways to look at it. 50% were in 1 to 25%. And then the other 50% were significantly higher. And this is excluding testing. So again, if you're, one of the things that we found in this report that was quite useful is to be able to understand how to calibrate what you're doing. And I think this gives you some good data on calibrating what you're doing. When we went a bit further and said, what are the costs that you have? Again, maybe not surprising, but good calibrating. Masks are number 1, followed by hand sanitizer, cleaning, and gloves. Little bit of a caution here. Gloves are not useful. And if anything, you know, it's one thing if you're working in a lab, but I'm separating for that. They are not useful for COVID. If anything, they are more dangerous. I'm not going to go into the people who say masks are dangerous because you could take your mask off and then get COVID. Well, by definition, if you're taking a mask off and you've got COVID on your mask, if you didn't have a mask, you definitely get it. But do take your mask off, you know, from, especially if you're in a crowded place, from the ear. Don't just hold the thing here and not wash your hands or your mask. But gloves are a whole different issue. Even amongst doctors pre-COVID, they take their gloves off wrong. I wish I had some gloves here. You take your gloves off and then you peel them right here. Well, by definition, if there are particles of any disease, they're now aerosolizing. If you have to wear gloves, and like I just did, I touched my face. If you have to wear gloves or want to wear gloves, take them off between your knees, take them off way below your face, maybe keep your mask on until after you take them off. Lots and lots of studies on masks, on gloves are dangerous. And that people, you know, they go into the supermarket with masks, they open the car door and then they take them off and then they're in a closed atmosphere. Not a good idea.
That's really helpful. You just described what I do.
Sorry. And then another piece that really surprised us, maybe not relevant to all of you, but we asked in our very first survey, what % of companies had an emergency plan? And 69% had some. You know, no, very, very, very few, like 10% had pandemic in it. But now when we asked companies, only 75% did. I can't emphasize this enough, have an emergency response plan. You know, whether you have a fire in your building or the worst in the worst, you know, an active shooter or otherwise, fire, floods, you know, it sounds like the plagues. Have one, have everybody have, I mean, if you're being super cautious, this is an area of real focus for me personally. I know this is going to sound silly to all of you tech companies, but have a piece of paper that has everybody's phone number. You know, crazy things happen and cell phone systems don't work and you can't get into your computers. Have kind of a cheat sheet of one piece of paper that you have at home with everybody's phone number. If you have a big facility, have one phone that's a landline wired. If systems go down, you would have the ability to use that landline. Now, this isn't pandemic specific, so throwing that in, but on pandemic, you need strong communications and strong plan, because it's those first few days and weeks that people are most confused, and that having a pre-thought out plan makes a big difference.
Yeah, thank you, Mara. I do have another question from the audience. Will COVID, oh, sorry, I've just lost it. Let me get, will COVID ever be over, or will we live with it forever? And how do you think this is going to look in 3, 5, 10 years?
I now believe COVID will never be over. Well, never, let's say 5+ years. We didn't think polio would be over, and it took 2 generations, but we're still getting vaccinated, hopefully, against polio. Delta is just too efficient. Now, maybe we come up with another type of vaccine, but this virus seems very, very durable, killing just the right number, excuse my saying it this way, right number of people to keep itself healthy. Yeah. I think that it will become endemic, and we will be dealing with it sort of kind of like the flu, with a higher death rate, at least 3 years.
So this is the pharmacologist in me speaking. How much activity is there in therapeutics? So, for example, in flu, we have Tamiflu, which can shorten it. Is there a lot of effort being put into making therapeutics if we're going to be living with COVID for a decade or more?
I'm not an expert in this area, but the answer is yes. There is a fair amount of activity, but nothing has, I was just reading an analyst report on this, nothing as of this moment looks interesting enough to be, relevant to on a global, on a public health basis. So there are anecdotal stories of this works and this works, but not broadly. I think, even though I'm focused on testing, that is the holy grail. If you could take something and reduce the severity or length of disease, then maybe you say it's not so risky. My worry, if you're working in the insurance industry, is the long COVID people, which is much less likely with vaccinations. The long COVID people are going to be expensive, and there are going to be a lot of them. Yeah,
I agree. There's another question. When traveling, how soon after you get back from a trip should you test, and should you also just quarantine?
48 hours, not I'm going to go visit somebody, I'm going to test when I get off the plane. Obviously if you have symptoms, it's a whole different thing, but otherwise 48 to 72 hours is the sweet spot after you're traveling. And should you quarantine? I think I talked about it a little bit before. If a workplace has no masks and you're going back to work and you want to have a very safe workplace, yeah, I would mask during those 48 to 72 hours. If you're going to go to visit a friend in a hospital, I would absolutely mask. So high risk environments, mask 48, 72 before you test.
Thank you. Well, I see we are coming up on the end of the hour, unless someone has an additional question. I think this has been hugely informative, hopefully for everybody. And again, you'll have copies of a lot of the material, and it is recorded. Mara, do you have some final words you'd like to leave us all with?
Yeah, well, first of all, personally, thank you for having me, but it's not about me. It's about, it's impressive, the playground's commitment for yourself and for your portfolio companies to be so focused on, health and safety. I have, in many ways, I don't want to say disappointed, but I was surprised in the very small role that employers have played until really the last 3 months. It's all been about government. And even under a Republican administration, a Democratic administration, it's all been about government initiatives. I believe now, as we go forward, there's going to be, for good or bad, more and more focus on employers playing an active role in the pandemic. And that next year, or maybe even this winter, people are going to ask you to give the flu and COVID vaccine in your office. They're going to ask you what your policies are. And that I think that we'll have at least a 50-50 shift of responsibilities. won't be all government saying what employers will do. Employers are playing a bigger and bigger role. And I think that's a good thing. But there is still so much misinformation there. So that for me is the macro point of view. From the micro point of view, you cannot over communicate. We didn't do a survey of individuals, but there are a lot out there. And the amount of misinformation, which I know you all know from Facebook and others, but even just doctors who have it wrong, over communicate, remind people of what it is, give them the confidence with your clarity as to the importance of testing, testing works, the importance of vaccination, vaccination is safe, etc., on a regular basis. And don't assume, and this is my view, don't assume because you told them 6 months ago that they got it. They need to be, survey after survey says they need to be reminded, and they want their employer to be more clear rather than less clear about their policies.
Well, thank you very much, Mara. I mean, we couldn't have been more fortunate to have you talk to us about this, your association with the Biden administration now, all the work you've been doing on it. We really thank you for educating us, talking to us, and sharing all this information. I also want to thank the audience for all of their time and participation. There were some great questions in there. Hopefully you got all of those answered, and we'll continue the dialogue. So thank you, everybody.
And thank you, Phyllis.